conjunction with MindMaze in Glasgow and in some other places. And I have to say, I've really enjoyed the previous 2 talks. I've been very keen to hear about the Queen Square service for some time, and it's something I really hope we can replicate one day in Glasgow. I'm the last person you want to hear about rehabilitation dose. The reason why 11 months after an ankle injury I'm still having operations is because the dose of my rehabilitation was too high and too quick, but hopefully it's very different in stroke. So I'm going to take you through a very little bit of truncated background, some of which you've heard before, and then just focus on the trial that we're currently doing and the progress that we've made. A couple of relevant disclosures relevant to today's session. So as you've already heard, arm weakness is a major priority for us in the healthcare system. It's a major priority for our patients. Roughly speaking, 3/4 of our patients will have upper limb weakness due to their stroke on presentation, and this will remain a severe problem, depends how you define it obviously, but in roughly 1/2. And having long-term issues with the arm is one of the major predictors of adverse life quality in the longer term. And this is one of our patients who was in one of our trials, and you can see in the blue just has a tiny lesion that transects the corticospinal tract and had very long-term problems with her arm. What you can see here is that our traditional approaches, we can certainly improve some measures of arm function at impairment level, but if we look specifically at the hands, some of the novel interventions that we've used to date haven't driven specific or significant improvements. So you've heard already about this potential window where we can maximise recovery, and I would certainly echo the sentiments that our own experience is not that window closes. We've had very good results with very high intensity regimens in patients many years after stroke, but I think we do recognise that there is a window that we can do better within our acute and our inpatient rehabilitation services. So we know that early rehabilitation is effective. We know that we need to deliver more of it, and one of the questions we're wrestling with today is how can we deliver more of it? And a recent Cochrane review, and we'll talk about this in a little bit of depth because it's important to give it the context that it deserves. A recent Cochrane review shows that virtual reality-based systems might be a promising adjunct to standard rehabilitation. And there's some evidence, albeit I think some is the operative word here, there's some evidence that it might help us provide a more intensive rehabilitation regimen. You've seen this data already, and again I echo the sentiments that while our guidelines in the UK and other guidelines in other healthcare systems have other figures of 30 minutes, 45 minutes or an hour, our state 45 minutes, that again is not based on any great degree of specific evidence, but it gives us a kind of benchmark where we can acknowledge the fact, and again you've seen this data already, we aim to give 45 minutes of physiotherapy, say, for somebody's impairment, so let's say it's the arm, but we deliver far less than that. And the number of hospital units within the UK, and we know that these problems are common in different healthcare systems, that meet all of their targets, so the physiotherapy target, you can see under 10% of our units deliver that guideline-based therapy. And it is important just to reflect on that because we've already seen excellent data on just how important really going for it and delivering high doses are in certain patients. If we can't get 45 minutes in more than 10% of our units, we're going to struggle on a mass level to implement these more aggressive interventions. So might virtual reality help? Well, when you look at this slide, certainly it looks like the effect estimate for a variety of different virtual reality interventions, and virtual reality here includes some of the commercial gaming systems, so it's not VR as you know you've seen with the MindMaze device and which you'll see subsequently, but nonetheless they were lumped together. You can see that the mean difference was 3.3 in this. So this is the Fugel-Meyer score data. You can see that the mean difference was roughly 3.3 points in the Fugel-Meyer score with the virtual reality based regimen versus the conventional treatment. So a modest treatment effect. It's important to say that although this is a Cochrane analysis, which lends some credibility, I think, and it's important to say that most of the studies were small numbers, and the quality of the included studies was generally reported to be low, and for some of the other analyses, some of the other assessments they made in the study, the quality of included studies was very low. So there's a signal there, but it's in that context of small studies with variable quality. But nonetheless, what you saw previously, an impairment measure that got better, a measure of movement synergy, and then similar was found for activities of daily living. So the hope would be that if we can drive improvements in Fugl-Meyer scores, there would be some confidence that they will translate to activities of daily living, but important to recognise that a 3-point difference on the Fugl-Meyer score is a relatively limited gain. So what we want to do on that background was take a CE marked virtual reality system, and remember that it's not a commercial gaming system, this is a bespoke virtual reality rehab device, and do a randomised parallel group study comparing that device with a more standard care approach, and we do need to spend some time about exactly what that means in early post-stroke upper limb rehabilitation. So to summarise the kind of underlying tenets, virtual reality will increase participant motivation, or at least that's one of our hypotheses, one of our tenets, that motivational therapy will keep patients training for longer, so it will be a useful mechanism to drive those levels of dose that we believe that we need. And increased rehabilitation therapy and dose, if we can do that, will improve functional outcomes. So they're the kind of underlying tenets and hypotheses that we're interested in exploring. And specifically for this study, and I think there was a very elegant point made in the previous talk about what are you trying to demonstrate from your trial. Are you trying to demonstrate that this will improve EQ5D scores, so you're going to need lots and lots of people? Are you going to try and demonstrate an improvement in modified Rankin scale scores, so you will need hundreds and hundreds and hundreds, possibly thousands of people? Or are you at the beginning of your evolution into clinical care, into clinical practice, trying to answer specific questions where you can use more realistic sample sizes, but yet hopefully still deliver data that's useful to clinical practice? So in this study we've focused on some of those concepts. We've focused on rehabilitation dose and motivation, and we will also generate resource use data alongside that. We will of course look at clinical outcomes and at functional measures, but our prime aim is to explore those issues around, is this a tool that can drive greater dose? Is this a tool that patients will engage with more? So we'll spend a little bit of time looking at the tool. I hope that many of you will have seen the device in action at the stand, and there is a device at the back right corner, so kind of behind you and on your left, that you can have a look at later on. And there are three main, if you like, components to it. There's the 3D motion tracking, there's a patient screen, so the screen that the patient sees, and then there's a therapist touchscreen that the therapist sees. And I guess the other major component of it is that it's mobile. We can take it to patients' beds, or we can take patients to it. Either or works and is relatively simple to do, and it comes fitted on the portable trolley. So in essence what happens is the 3D motion tracking will map the movement of the person onto the screen, where it will appear as an avatar. So the person will be doing a task and can see on the screen that task, engaging in a variety of interactive games. And I think what's nice there is that you can give, even with patients of a fairly low level or very low Fugl-Meyer score with limited movement, you can put a functional kind of emphasis on some of the tasks by they're picking up an object when they're doing this sort of movement in somebody with very limited movement. So we hope that with time the games can become more functional, and even at very low levels of impairment we can engage people in more functioned tasks. The games can be made more difficult by increasing the number of repetitions, increasing the speed required of movement, increasing the difficulty. And one of the things that we're beginning to experiment with in the device is that it can actually deliver mirror therapy. So you can deliver traditional therapy paradigms, or you can do a mirror-based therapy session with your patient. And the setup is fairly simple, and I think this is actually quite an important practical point. Our therapists, when we ask them, why can't we do better with therapy, and it's the same as all of us feel on our ward rounds. You spend 5 minutes with a patient, 10 minutes writing in the notes, and I think therapists tell us that this is an issue for them. What's nice here is that they can begin a game, they're decoupled for 3 or 4 minutes, and in that period of time they can do some note writing, and they don't have a 20-minute gap after patient 1 before they can start seeing patient 2. So we're going to explore those issues in the trial as well. So who are we studying? I think this has been beautifully outlined already. We're focusing, and you can see on the 4th point down, we're focusing on this moderate group that you saw in the first talk. So people that can do some things with their hand and have Fugl-Meyer scores of between 20 and 40. They're 1 to 6 weeks post-stroke, so we're trying to focus in on that window where we believe there may be greater potential to intervene. And we're including a fairly wide number. We're excluding patients with cognitive impairment for consent issues, and we're excluding patients with moderate to severe hemi-neglect. And it's only anterior circulation strokes, first ever strokes, that are being included. So everybody is recruited, obviously, consented, has a baseline evaluation, and thereafter they are randomised to a MindMotion PRO based therapy protocol or a more standard based therapy protocol. And using the word standard can be a bit confusing because everybody also does their standard NHS or wherever they are, there are other countries involved, they do their standard physio that they would be doing anyway if they weren't in the trial. So what we're comparing is over and above the standard is MindMotion PRO therapy with some form of dose matching so that we can measure engagement with the therapy versus engagement with a more traditional method of increasing dose. So that's an important distinction to make. In the first week, it's quite hands-on in that we're training the participants in how to use the device. They're becoming familiar with the device, and likewise, we're training them in the grasp-based, more standard paradigm during the first week. They all get 20 minutes, and then thereafter we allow them, if they want to, so we can get some idea of willingness to engage, to do more in a facilitated but more kind of less specific, less dictatorial environment. Weeks 2 to 4, they'll again come up every day, and it will be a facilitated type therapy session, so they will have access to the relevant equipment, and we'll just measure how much they do, how many repetitions they do, how much they engage in it, how much they enjoyed the engagement with it. At the end of that period, they'll have their evaluations, and then they'll be seen 12 weeks after that for a more long-term 16-week evaluation. So our primary aim is to just see to answer the question as to whether the use of the virtual reality system will engage patients more and allow a difference in rehabilitation dose. Now, it's important to say that we haven't attempted to deliver those huge changes in dose that we think would be required in the longer term to drive big functional gains. We're just measuring in a more clinical system, if you like. So we're going to look at the difference in rehabilitation dose, so the number of time that a person in the MindMotion PRO arm versus the standard arm spends in their active additional rehabilitation, and we'll also look at the number of exercises, number of repetitions that they do, not counting what they do in their 30 minutes as they should be doing as a minimum every day in the protocol of standard care. As I mentioned before, we will of course look at a variety of different scales. We'll look at the modified Rankin scale, we'll look at other quality of life and functional measures, and we will look at the motor scales, the impairment scales, and some of the more functional tests in detail. And I think what we're perhaps most interested in is the intrinsic motivation inventory, some of the motivational measures, and we'll also gather, as we said, some resource utilization data. So there are aims and there are goals, and the study is now open. It's approved in 4 countries, and sites are now recruiting. So far we've recruited participants from 3 sites, and while I'm in Prague hobbling around on sticks enjoying the nice weather, I'm told that we might be recruiting a patient today is being screened, so the team are at least doing some real work at home, which is good. We're roughly a quarter of the way through, and we hope that we'll ramp up our recruitment and bring things to a timely conclusion. So that's our clinical trial that's being done to answer those questions around dose and motivation. And the second exercise that we just want to highlight to you is the LeMans VR Neurorehabilitation Registry, which is going to take units that are using the device, because it is CE marked and it's available for use, using the device, but collecting the data because it's a new intervention in a prospective consented registry that will incorporate data around baseline characteristics, around the intervention, around the degree of usage, the games, and optional things such as imaging data, outcome data thereafter, and patient-therapist feedback. So obviously sites that are going to be using the device, we hope that they'll engage with the attempts to develop the real-world registry data. So in summary, virtual reality therapy has potential. I think the Cochrane analysis suggests that, but we do have to be wary around the quality of some of the included studies, and we need to run high-quality clinical trials to assess that further. The MOVE Rehab study will tell us whether it engages patients more in rehab and increases therapy dose. And a prospective registry of clinical users will provide real-world data that we hope will sit alongside the trial and help us plan how these things might be implemented into clinical practice. And finally, just to acknowledge the MindMates team for all their support in getting the trial up and running, and my absent friends who are at home doing real work while we're here at the conference. So thank you very much.
Thank you, Dawson. Out of time, we have to move
Okay.
forward. And now it's Andrea Serino from Lausanne.